Okay, welcome to our presentation on refeeding syndrome. So what is refeeding syndrome? It represents a group of clinical signs and symptoms that are commonly observed in severely malnourished and cachectic patients, resulting from nutritional supplementation via oral, enteral, or parenteral routes. It is in response to nutritional load. The body tries to reverse its adaptation to the starved state, and therefore it results in fluid and electrolyte imbalances, including hypophosphatemia and hypokalemia.
So, some signs and symptoms of refeeding syndrome include fatigue, weakness, confusion, difficulty breathing, seizures, irregular heartbeat, and edema. And this is resulting from the altered electrolytes, such as hypophosphatemia. So, the pathophysiology of refeeding syndrome. In prolonged starvation, weeks to months, glycogen stores are expended while proteins are conserved for intracellular enzymatic and structural functions, leaving fats as the predominant source of energy. During this time, absolute size and volume of cells of the liver, heart, brain, and more importantly, muscle decreases, probably due to a combination of an energy deficient state, loss of intracellular storage macromolecules such as protein and glycogen, and adaptation to fat metabolism. And these abnormalities can be fatal if not treated appropriately. So, in other words, extended periods of nutrient deprivation causes the body to efficiently use and preserve available energy. As starvation progresses, these energy reserves, vitamins, and electrolytes are depleted. And when there is a reintroduction or increased number of calories too quickly, metabolic and electrolyte abnormalities can occur. So altered electrolytes and refeeding syndrome. The levels of all these electrolytes, phosphorus, potassium, and magnesium, decrease as a result of starvation, and each of these electrolytes plays a key role in the human body. So first, low phosphorus, hypophosphatemia. Phosphorus is a vital component of adenosine triphosphate, or ATP, which is the main form of energy in humans. Prolonged starvation leads to hypophosphatemia and decreased levels of ATP. And then there's low potassium or hypokalemia. Insulin stimulation of the sodium potassium ATPase enzyme is responsible for bringing sodium out of the cell and potassium into the cell. It is also responsible for nerve impulses and contraction of muscles, but decreased potassium due to starvation results in impaired transmission of electrical impulses, increasing the risk of cardiac arrhythmias or an irregular heartbeat. And then low magnesium or hypomagnesemia is when low magnesium impairs potassium reuptake in the nephron or the kidney, which further contributes to the loss of potassium. And also, when somebody eats carbohydrates after not eating for a while, insulin is released, which causes cellular uptake of phosphate, leading to hypoxia, myocardial dysfunction, and respiratory failure. So the American Society for Parenteral and Enteral Nutrition, or ASPEN, Parenteral Nutrition Safety Committee, and the Clinical Practice Committee developed consensus guidelines for identifying patients with or at risk of refeeding syndrome. And these diagnostics consist of a decrease in any 1, 2, or 3 of serum phosphorus, potassium, and or magnesium levels by 10 to 20%, which is mild, 20 to 30%, which is moderate or greater than 30%. And then organ dysfunction resulting from any of the above electrolyte deficiencies and or due to thiamine deficiency, which would be very severe. And this all would be if it occurs within 5 days of reintroduction of nutrition.
Certain conditions can increase the risk for refeeding syndrome. So these include psychiatric conditions such as eating disorders, chronic alcoholism, and depression. Anorexia is the most common predisposing diagnosis for refeeding syndrome. Cancer and chemotherapy treatment also puts patients at an increased risk. Malabsorptive states, including short bowel syndrome and bariatric surgery, cause various vitamin and cofactor deficiencies that can increase risk. And lastly, diabetes and hemodialysis patients are also at an increased risk. The best way to prevent refeeding syndrome is to recognize patients who are at risk, also providing adequate electrolytes, vitamins, especially thiamine, and micronutrient supplementation prior to initiating nutrition, maintaining adequate fluid volume, and monitoring the patient is also critical to prevention.
So in order to get the patient optimal nutrition, an interdisciplinary approach is needed. So in a lot of hospitals, nutrition and malnutrition is managed only by the dietitians. However, to effectively manage the nutrition in patients, a collaboration among all the members of the healthcare team is needed. So who should be involved in the management of the patient's nutrition? All members of the clinical team must be involved. So each healthcare provider on the team has a different role in managing malnutrition and nutrition of the patients. So nurses perform the initial nutrition screening and they develop innovative strategies to facilitate patient compliance or adherence to the nutrition. Dietitians complete the nutrition assessment and the diagnosis and then develop evidence-based interventions. Pharmacists evaluate the drug-nutrient interactions, and they also have an important role in evaluating blood work to assure the appropriate electrolyte repletion and the appropriate initiation of the parenteral nutrition or even enteral nutrition. And finally, physicians, which include hospitalists, oversee the overall care plan, and they also document and support the reimbursement for services. So nutrition intervention for malnourished patients are a cost-effective and low-risk strategy to improve their quality of hospital care, but it requires, again, the interdisciplinary collaboration. And so there are 6 principles that have been identified that are deemed essential elements to optimal patient nutrition. This is a diagram of the 6 principles. So first, it starts with creating an institutional culture. So you want to make sure that the healthcare team members know that nutrition improves patient outcomes. And you want the environment to support an adequate and appropriate nutrition intervention. Once you do that, we move on to the second principle, which is redefining clinicians' roles to include nutrition. You want to empower the dietitians, and you want to make sure that you empower the nurses and the physicians' leadership as well. So it takes teamwork to include a proper nutrition in the patient's care plan. Principle 3 is recognizing and diagnosing all patients at risk. So you want to make sure that we're identifying the patients that are malnourished, and we want to use valid screening tools and criteria to assess and properly diagnose malnutrition. Principle 4 is rapidly implementing interventions and continued monitoring. So within evaluating a patient as at risk, we want to make sure that we give the patient's nutrition within 24 hours of that at-risk screening. And we want to make sure that we're monitoring the patient's food and oral nutrition as well. Principle 5 is communicating nutrition care plans. So we want to make sure that we have mild, moderate, and severe malnutrition care plans. And we want to make sure that we're having discussions about nutrition among the healthcare team members to make sure that the patient is optimally getting their nutrition. And finally, the 6th principle is developing a discharge nutrition care and education plan. So after the patient is done with their stay in the hospital, we still want to make sure that they're going to be getting the adequate nutrition once they're discharged and go back home. So this includes patient education, as well as educating the families and the caregivers. And we want to make sure we're having good communication between healthcare providers and the patient. These are now the 5 steps for the optimal collaboration among the healthcare team members. So the first is empowerment of all the clinicians and all the healthcare team members. The second is recognition and diagnosis of all the patients as high risk for malnutrition. The third is a same-day automatic intervention for all at-risk patients. So once they're deemed at risk, we want to make sure we're giving them the proper nutrition within 24 hours. The fourth step is education and involvement of all patients in the nutrition care plan. So making sure we're communicating to the patient, but as well as their families. And 5, appreciation of the value of nutrition by all hospital stakeholders. And this can only be achieved with the interdisciplinary approach from all the healthcare team members.
Pharmacists are also extremely involved in the parenteral nutrition process. Parenteral nutrition offers a more controlled way to reintroduce the nutrients to patients at risk for refeeding syndrome. We can introduce the micronutrients and the macronutrients we want in the amount that we want through this process. Nutrition support pharmacists are involved in the parenteral nutrition process all the way through. Some of their responsibilities include ensuring the appropriate dosing of all nutrients, that all micros and macros are appropriate for that patient according to their labs. They ensure the compatibility of all components, whether it's a nutrient or a non-nutrient. TPNs are very complex products, and in order for them to be soluble, there's lots of emulsifiers. They oversee the preparation of parenteral nutrition in the pharmacy clean rooms with their technicians, and they determine the stability of the parenteral nutrition products based off the amount of lipids or dextrose in a preparation. Pharmacists also help in developing a nutritional care plan for patients with refeeding syndrome. Some things pharmacists add a lot of value are understanding how medications change nutrient needs. Certain medications can affect electrolytes especially. An example of this is certain antihypertensives can worsen hypokalemia, which is a concern we have, as well as nutrients that are in other drug products when they are excipients, not the actual pharmaceutical product. For example, certain anesthetics like propofol are on soybean oil, and you need to account for the lipids. Certain infusions are in dextrose, 5%, and those need to be accounted for the patient's intake. Furthermore, the pharmacist monitors the patient, orders appropriate labs to see if the plan is working and what changes need to be made, and they analyze the risk and benefits of increasing the nutrients. So we can start the patient on higher nutrients and eventually shift them over to enteral nutrition without increasing the risk of refeeding.